The views and opinions of findings and/or devices discussed in this podcast are those of the host, subject matter experts, and/or guests. Facts represented constitute our understanding at the time of the podcast, whereas updated factual information may be developed. They should not be construed as pronouncing an official Department of Defense's position, policy, decision, or endorsement. The hosts and guests of CUBIST may be defense contract personnel who support TBI-COE. Status of all hosts and guests will be identified during introductions to the podcast. Hi, welcome to Clinical Updates in Brain Injury Science Today, or CUBIST, a podcast for healthcare providers about current research on traumatic brain injury, also known as TBI. This program is produced by the TBI Center of Excellence, or TBI-COE. I'm your host, Dr. Kati Monti, a contractor in support of TBI-COE. Today, I'll be speaking with Dr. Donald Marion, a neurosurgeon and TBI subject matter expert, who is also a contractor in support of TBI-COE. Don and I will discuss a study titled Examining the New Consensus Criteria for Traumatic Encephalopathy Syndrome in Community-Dwelling Older Adults by Douglas Terry and colleagues, and published in the Journal of Neurotrauma in January 2024. Don, thank you for bringing this article to our attention. Chronic traumatic encephalopathy, commonly referred to as CTE, and traumatic encephalopathy syndrome, or TES, are definitely hot topics these days in brain injury research and among service members and veterans. Can you share with our listeners a bit on the historical background of these diagnoses?
Sure, Katie, and good speaking with you again. As you well know, Katie, there is concern among many service members and veterans about the long-term effects of the repetitive head impacts they may be exposed to in the military. For nearly 100 years, clinicians have documented unique brain pathology associated with repetitive head impacts. And in 1957, MacDonald Critchley, a British neurologist, introduced the term chronic traumatic encephalopathy, or CTE, to characterize that pathology. In 2005, Bennett Omalu first described the abnormal deposition of tau protein as a hallmark of CTE in an NFL player who died in midlife. Tau accumulation in specific locations of the brain was subsequently described in multiple publications from a group at Boston University, which strongly suggested that CTE was the result of multiple concussions seen most frequently with tackle football. However, there are limitations to the generalizability of their findings because of selection bias. And what do I mean by that? Well, specifically, the Boston University group has made it clear through the media and scientific publications that they are most focused on deceased football players. As a result, they are examining the brains from a group of subjects that is not diverse, and they are looking for patterns in data to confirm ideas or opinions already held. In 2015, the NIH issued a consensus statement that specifically defined the histopathologic characteristics of CTE to include tau protein deposition in specific brain locations, most likely related to multiple concussions. Importantly, however, the NIH statement made it clear that CTE was a post-mortem diagnosis, and no consensus was reached about the clinical characteristics of CTE prior to death. In April of 2019, a group of 20 clinician scientists participated in a modified Delphi process sponsored by the National Institute of Neurological Disorders and Stroke to attempt to define diagnostic criteria for traumatic encephalopathy syndrome, a pre-mortem clinical diagnosis that would be consistently associated with the neuropathology of CTE. A provisional level of certainty for CTE pathology was proposed based on specific repetitive head impact exposure thresholds, though not actual concussions. In addition, core clinical features, functional status, and additional supportive features, including delayed onset of motor signs and psychiatric features, were specified. The intention was that the criteria would be revised as updated clinical and pathologic information and biomarker data became available.
Thanks, Don. That was a great summary of the background as to why this study is so timely.
Katie, I do want to emphasize that a key element of the Traumatic Encephalopathy Syndrome consensus diagnostic criteria was repetitive head impact exposures. To be sure, I can't stress this enough, no clinical or other evidence was presented at that conference that definitively linked any clinical symptom or sign or cluster of symptoms or signs with the brain pathology associated with CTE. In fact, a study published in 2022 found that when the consensus criteria were applied retrospectively to samples of retired athletes, American football players and boxers, for example, the prevalence of TES was only 21.3%, much lower than I would have expected.
Wow, that is interesting. So why was this study done?
So the purpose of the study was to examine the 2019 NINDS consensus criteria for TES in a cohort of community-dwelling older adults and determine the association between TES criteria and a history of repetitive head impacts.
And how did the researchers carry out the study?
This was a cross-sectional, survey-based study examining TES symptoms, previous sport-related repetitive head impacts, and a variety of current health difficulties. The survey took an average of 30 minutes to complete and was taken remotely in most cases. All participants were at least 45 years old and were community-dwelling adults enrolled in a university-based Memory and Alzheimer's Center registry. To participate in the registry, you had to be free of any major psychiatric disorder, such as bipolar disorder or schizophrenia, and could not have been diagnosed with Alzheimer's disease or any other neurodegenerative disease at the time of enrollment. Anyone who was subsequently diagnosed with those diseases was excluded from the study. To meet symptom criteria for TES, participants had to report progressive changes with memory, executive functioning, such as problems planning things in daily life, organizing my daily schedule, inhibiting impulses and multitasking, and or neurobehavioral dysregulation, such as significant problems controlling emotions or explosiveness, impulsivity, rage, violent outbursts, or mood swings. All of those for at least 1 year. Symptoms of depression were measured with the Patient Health Questionnaire 9, or PHQ-9, and symptoms of anxiety with the General Anxiety Disorder Tool, or GAD-7. Questions related to dementia were included, as were questions about quality of sleep, chronic pain, and migraines. To meet the criterion for substantial exposure to repetitive head impacts via contact sports, participants had to have reported at least 5 years of contact sport exposure, with 2+ years in high school or beyond. Football, soccer, hockey, lacrosse, martial arts, boxing, and wrestling were considered contact sports. Participants in the study also reported whether they had exposures to repeated head blows, breaching, blasts, heavy weapons, controlled detonations, IEDs, or domestic violence involving head blows. For the purposes of this study, none of these exposures were considered as repetitive head impacts, according to the TES consensus panel, and were excluded from the primary analysis because they did not meet the sport exposure criterion.
That's interesting. Don't the consensus diagnostic criteria include repetitive head impacts other than those that are sports related? Why didn't they include these individuals in the analysis?
I'm not sure, and that had to do with that meeting that was held in 2019 to define the criteria for TES. My suspicion is that it was primarily a result of the influence of the Boston University group, which really felt fairly strongly they should focus on tackle football and sport-related concussion. RHI, related to mechanisms other than sports exposure, including military service, is a small part of the consensus TES diagnostic criteria. However, the researchers for this study did not include participants who reported RHI from these other mechanisms and who also did not meet the sports exposure criteria. Because for low-level blast and domestic violence exposure, they felt those kinds of exposures were not well defined. So the final sample included 507 older adults with a mean age of 70 years. 65% were women, 95% were white, and 66% were married.
So what did they find?
Kati, 26.2% of the group endorsed having one or more core clinical features of TES, which together with a history of repetitive sport-related head impacts would meet the diagnosis of TES. But those with a history of contact sport exposure were not more likely to meet TES criteria compared to those who did not. It is important to note, however, that only 32 participants met the repetitive head impact sport exposure criterion. However, those with current depression or anxiety were 12.6 times more likely to meet the TES criteria. Those with current psychiatric symptoms were 16 times more likely. Those with chronic pain, 1.8 times more likely. Males, 1.9 times more likely. And those with sleep problems, 2.5 times more likely to meet TES criteria. The sport exposure criteria, age, and current pain were not significantly associated with TES. 247 participants denied a lifetime history of head impacts, no previous concussion history, no contact sports exposure or military exposure, and no history of head trauma from domestic violence. Because they had no history of repetitive head impacts, they did not meet the criteria for TES. Approximately 20% endorsed one or more core features of TES. Nearly 80% of these neurotrauma-naive participants with clinically significant anxiety depression were likely to endorse one or more of the core clinical features of TES. In fact, those who met the sport exposure criteria or repetitive head impacts were significantly less likely, not more likely, but less likely to have sleep problems, endorse a previous history of depression, or have a previous history of psychiatric disorders than those who did not meet the sport exposure criteria and denied other forms of repetitive neurotrauma.
That's surprising, Dawn. It suggests that there might be late-life psychological and behavioral advantages to having participated in contact sports earlier in life. So what were the limitations of the study?
58% of this cohort had no previous history of concussion, and 85% did not meet the sport exposure criteria and denied other forms of repetitive head impacts. In fact, as I mentioned before, only 32 participants met the sport exposure criterion, which is, again, a total of 5+ years of contact sport exposure with at least 2 years in high school or above. So perhaps a larger sample is needed to better understand the relationship between the TES criteria and sport-related repetitive head impacts. I think a second concern is that as a survey, all data was self-reported and therefore subject to recall bias. An experienced clinician is usually recommended, for example, to obtain valid cognitive data, such as that obtained through neuropsychological testing. Thirdly, and most relevant for our military providers, is that this study did not include any military-specific data. If any of the participants were veterans, the authors did not report this information. So generalizability of these results may be limited due to a homogeneous participant pool with limited diversity and a lack of military representation. Future studies in military cohorts would strengthen the external validity of these findings.
Thanks, Dawn. So what are the key takeaways for primary care providers in the military?
Kati, approximately 1 in 4 older adults met the symptom criteria for TES, most of whom had no history of repetitive neurotrauma. Mental health problems and sleep issues were more likely to be associated with the symptoms associated with TES, whereas reporting a history of repetitive head impacts in contact sports was not related to TES in this sample of older community-dwelling adults. These data suggest that the new consensus diagnostic criteria for TES may have low specificity and may carry a higher risk of misdiagnosing those with other physical and mental health conditions. There is concern that older adults who participated in contact or collision sports early in life and who currently have mental health problems may be misdiagnosed as having TES, given that most older adults without a neurotrauma history, but who have mental health problems, would likely meet the symptom criteria for TES. Military providers should continue to follow existing clinical practice guidelines and recommendations and provide clear treatment plans focused on symptom management.
These are great takeaways, Don. I think it's also important for clinicians to remember that the TES diagnostic criteria are only for research purposes at present.
Yeah, that's correct, Katie. The TES diagnostic criteria continue to require validation across other populations before they can be incorporated into the medical lexicon.
Thank you, Don, for this discussion on such an important topic in brain injury science. So that's all the time we have for today. You can stay up to date on future episodes by subscribing to CUBIST on iTunes, SoundCloud, Stitcher, or wherever you listen to podcasts, where you can also find links to the articles we discuss and other relevant resources. CUBIST is produced and edited by Vinny White and was hosted today by me, Dr. Kati Monti. It is a product of the Traumatic Brain Injury Center of Excellence, a branch of the Research Portfolio Management Division under the Research and Engineering Directorate of the Defense Health Agency, led by Branch Chief Captain Scott Coda, Medical Corps, United States Navy. Thank you for listening to this episode.